When you work as a PA in the emergency room, you're already on edge. And in a day with 30 or more patients in a row, you see the chief complaint come up and it says head pain. You think, well, it could be, that tumor that's finally gotten large enough to cause an impact. Could be the result of blunt force trauma. Could be a cerebral aneurysm. But no, it's your neighbor. And he's been sick for 2 days and he'd like you to prescribe some Tylenol because he's not feeling very well. He could have bought it over the counter at Rite Aid. It's the green mucus and the mild fever. It's the nosebleed that is already finished and resolved. It's the abdominal crampy pain from a midnight drunken spicy food binge. Painful, but not an emergency. And as we all know, these kinds of things are showing up in our emergency rooms all the time, and they're clogging up the system. Now, we get it. The emergency room for the patient is the place where they go when they are scared, when they are in pain, when they don't know what else to do. It's got the tools, it's got the people, it's got the resources. 24/7, 365, the lights are always on, the doors are always open, and there's always somebody there. And so we get it. When you are in pain and you need help, that is where you go. However, as providers, we see that the system is being stretched, and it's stretched thin. So we began this project to see if we could understand some of the root causes why these non-acute presentations were showing up in our emergency rooms.
So, we figured that improved access to, as well as a better understanding of basic health information, was necessary to educate people on health concerns that did not necessarily need to go to an urgent care or an ED. We saw an article that showed that ED visits, inappropriate use of EDs, result in more than $1,000 per visit, whereas urgent care visits average about $150. An article by the CDC showed that nearly 80% of people misuse the ED just because they didn't have another facility to go to. Another article by the NPR showed that 22% of people opted to going to urgent care facilities because they were more convenient and they thought that they'd be seen in a faster amount of time. So we reached out to healthcare providers that we've worked with in the past, and just others that we know who work in emergency departments as well as urgent care facilities, to see what are some of the top presenting health concerns that come up in their practice. So they listed, from a number of things, we determined that the 5 top reasons why people visit for non-emergent cases are viral upper respiratory infections, joint pain, swelling, and injuries, viral conjunctivitis, superficial burns, and another one was simple lacerations. So based on this information, we decided to reach out to a community to educate them on the top 5 non-emergent cases that do present to these facilities, and at least give them criteria on determining the urgency of these problems, and also, if they're non-emergent, how they can remedy these issues from home.
So when we were really thinking about what group we wanted to work with, there's so many options. You could go to any city, you can go to any neighborhood, any SPA, and you would be able to have an effect on this problem of trying to educate people before they go to urgent care, before they go to the ER, just give them some basic health info that can divert them, somewhere, maybe to an urgent care or to a primary before going to an ER for their, nosebleed that's over. So we really kind of wanted to reach out, though, to people who might need the information the most, and that was where some of our advocacy came in. I remembered while working at Dr. Diartola's clinic, that which treats primarily low-income people without a lot of insurance coverage, that every Tuesday and Thursday they had a food bank there that opened, and some of you probably saw the line outside, where people would just be hanging out there for an hour waiting for the bank to open. And so these are people who are coming to get food donations. They're just killing time, they're waiting. And we thought, well, these people might actually be receptive to our message because they're kind of bored. And versus, I personally hate going to a grocery store and hawking on people, and I just don't like it myself. I don't like being approached that way. So that's kind of where we got the idea to go to this place. From my work in the clinic and other people's work there, we knew that there were a lot of folks who spoke Spanish only or who were bilingual, Spanish-English. So we did have all our materials in both languages during our presentation. So this is where we went, our Savior Center in El Monte, outside their food pantry. And this is Dr. Diartola, where he works as well in the clinic. Food pantry's right next door. To get our interaction to be less, static and more dynamic and maybe appeal to multiple senses, I had this thing I remembered seeing in a museum. So up on top here, what this is, it's an exhibit in the Natural History Museum in San Diego, and it's these I guess I'd call them flipboards. And I remember going there and it was so packed. It's like the most low-key exhibit, but it's on native and non-native species of plants and animals in California. And there were kids doing this, and all you do is you walk along this tabletop and you just flip these things. It's is it native or non-native? And it's a picture, and then you flip it. It's super basic. But everybody was into it, and they were all going through all of them and just actually interacting with this simple exhibit. So that was the idea. We made, these are copies, but we made these flipboards with each of our pre-test questions, and we gave people tokens so that as they walked by, they could read the question, vote whether they thought the question was true, yes or no, using little tokens. So yes if they agree, no if they don't, or seal no. So it kind of works with both languages, English, Spanish, then they flip it, they can see the answer. And so that was kind of the idea. So this got all of our pre-test data collected on the basic health questions we chose to do. And then we also gave a post-test afterward that was written. So English on the front, Spanish on the back, and that's how we got our post-test data. So that was just what our intervention looked like. We, really wanted it to be kind of colorful and interactive, and make it less boring.
All right, so we had done our research, we had built our project, we picked our location, and it was finally the time that we were waiting for, the moment of truth, time for the advocacy and education of the population. So what actually worked? The swag. So nothing brings in people faster than giving them some free stuff. Through the advocacy of Capstone School of Medicine and also the Aaron Cohen Health Center, we were able to give some small useful trinkets like pens, flashlights, and mini first aid kits to hand out to our participants. We would even carry the groceries to their car to build interest in our The tickets. People loved that it was interactive. It was fun to go along, to quiz themselves, to vote with the tickets, and to learn along the way. This drew in more attention than a simple interview or questionnaire might have. It was also easygoing. It was not intimidating. We had a bright, colorful display with friendly, easygoing people to help guide them, not push them through the process. So the unexpected. We didn't realize how much guidance these people would need, how much we would have to hold their hand throughout the process. Despite our hard work and great design, many of the questions and concepts were still over the head of the participants. This kind of speaks to the low health literacy of the population. Thankfully, there was enough of us there to help guide them and educate them throughout the process. What we were lacking, we did not have any materials in Chinese. We didn't know how big of a issue this would be. In the future, we would just at least have a handout in a couple other languages so we could communicate with these individuals. And the superfluous. So our big, beautiful poster board was scarcely looked at. Well, it was nice and fancy and made the table look good. If anything, it was more of a distraction as gusts of wind would send it crashing down, nearly splashing into the fountain nearby.
So in tallying the number of participants who answered yes or no on our pretest, and in our final post-test questions where participants were asked to recall answers to questions on our pretest, we came to the conclusion that overall our participants were very receptive and positively influenced by this exercise. And our combined data reflects this positive trend. For question number 1,
If you get a cold and the cough isn't gone in 1 week, go to the doctor.
False.
there was a 41% increase in the number of people who answered correctly on the post-test compared to the pre-test. For question number 2,
If a person injures a limb and they experience pain, swelling, and bruising, has the person definitely broken a bone?
False.
and question number 4,
If a nosebleed lasts over 10 minutes, you should go to the doctor.
True.
there was a 41% increase in the number of people who answered correctly. Now, oddly, for question number 3,
If a person's forehead feels warm, it means they have a fever.
False.
there was a 21% drop in the number of people who answered correctly. Now, this can be attributed to the wording of the question, and it can also be due to the fact that the question asked for more specifics than any other question in asking for the exact temperature that is considered a fever, which is 100.4. So participants weren't able to recall that information on our post-test. Now, the greatest percentage increase was actually in question number 5.
If you are sick and the mucus is green, you need an antibiotic.
False.
There was a 49% increase in the number of people who answered correctly. Now, in observation during administration of our pretest, participants seemed shocked and receptive of the information given to them in question number 5. Also, considering that this was the last question in our series of pretest questions, I think that participants had an easier time remembering this because it was just fresh in their heads. In the data gathered from our post-test, 56% of participants felt more comfortable and able in taking care of minor illnesses at home after this exercise. And then in the future, 67% will consider treating some of these things at home rather than going to an urgent care ER.
So what did we learn? We felt like our intervention was definitely successful. One of our stars was we reached the correct SES group that we were looking for. They were less medically and health literacy educated than we expected. But that's kind of what we were going for. We were looking for people who didn't have a high amount of knowledge. We were looking to teach them and educate them. So that was definitely one of our stars. One of our wishes, however, was our language barrier. As Luke touched on, we were surprised how many patients were only Chinese speaking. We knew going into it that we'd have a majority of only Spanish speaking, or mostly Spanish, maybe a little bit of English. So in the future, like Luke touched on, we would want to do more materials or a handout or something in Chinese. Another one of our wishes actually was that we had gone through and tracked each participant individually in our data collection instead of just doing kind of an overall thing. And that would have allowed us to look at Spanish speakers versus English speakers. It would have allowed us to see if one individual did really well on the pretest, if they did just as well on the post-test. We would have wanted to see more things like that in our data collection. Another one of our stars is our health literacy. Again, we were talking to people and we were able to adapt our presentation, the way that we had set up our intervention. We were able to adapt and talk to them and be able to hold their hands. And really, we felt like we really got some education out. We felt like we really were able to help some people. So what we wanted to point out was this is a real problem. Like, people do need to know basic health information. They come to us because they don't know. So just taking a few minutes to talk to our patients, just taking that time to explain why they don't need an antibiotic, or why we might give them one, but in the future they may not need one. That can make a difference for them. It can help decompress our ERs in the future as well. Thanks so much, guys.